I titled my talk, Personalized Care Plans, Harnessing Technology and Patient-Reported Outcomes to Drive Quality Care Across the Cancer Continuum, because that's what really we're striving to do. So today I'll provide a brief overview of challenges to providing coordinated patient-centered care across the continuum. I'll just tell you a little bit more about what we believe to be an innovative technology and content solution designed to address these challenges, which we call the OnQ Care Planning System. And then, as I already stated, to describe preliminary feasibility, usability, and satisfaction data on the use of the system in breast and gyne populations, cancer populations at 2 cancer centers in the U.S. And you'll see that the pilot data I'm presenting are not just confined to the post-treatment survivorship care setting. We at OntoHealth really envision that cancer survivorship is consistent with the NCCS definition as being any individual diagnosed and or his or her family from that time point of diagnosis and across the care continuum. We certainly do recognize the Institute of Medicine's definition of survivorship care as really predominantly focusing on the care of individuals post a defined acute period of treatment, and we provide survivorship care plans to help drive care coordination and quality care management in that phase of the cancer care trajectory. But we really envision that we start where this big gray arrow starts with what our platform is intended to address and what the research we do with academic partners using our platform capabilities is designed to address. So from care planning and integration of palliative care and evidence-based symptom management and survivorship care across the care continuum from diagnosis through treatment into that post-treatment survivorship care and inclusive of end-of-life care in the context of cancer where that is relevant for individuals. So hopefully that provides a good overview. I'm sure I'm preaching to the choir on this call when I call out some of the challenges in cancer care. Very fragmented and quality is inconsistent. There are many care providers that care for any given individual cancer patient and his or her family, and the coordination and communication between those providers is frequently not seamless at any given point across the cancer care trajectory. The quality that's provided is also inconsistent. One of the things that really drove me to leave a 20-year career in academic nursing was, and to leave doing primary research and symptom management was my frustration with the fact that so much evidence is out there to date that doesn't get leveraged into actual clinical practice. And so we see that in lots of care experiences and patient experiences across the cancer care continuum. We see that there's a good proportion of patients who report significant distress at some time point along the care continuum, and that's been associated with poor clinical outcomes and increased costs. We certainly know that physical symptoms are prevalent across the continuum in the cancer population, from diagnosis through treatment, even into and well into the post-treatment survivorship continuum, and certainly during an end-of-life period of care. So these symptoms are prevalent, and yet study after study has shown that we aren't adequately screening for, assessing, and managing and keeping with the evidence. There's many more citations that I could have put on this slide here. These factors lead to statistics such as those you see here from Deb Mayer, a nurse scientist at University of North Carolina, who did a population-based study in North Carolina where she documented that 56% of cancer patients visit the ED each year, most of these resulting in hospitalizations and a fifth of these resulting in readmissions within 30 days. This is her data combined with some other data in this space. And symptoms are a top reason for these healthcare utilization events. And these are for folks typically on active treatment, but we do know cancer survivors in the post-treatment period also represent a portion of this population. The most common symptoms that lead to these healthcare utilization events are gastrointestinal symptoms, dyspnea, fatigue, and pain. Now, if you look at palliative care, so palliative care, depending on how you define it, well, actually independent of how you define it, is not systematically integrated. So if you view palliative care as supportive care that should be integrated across the cancer care continuum, we don't do a good enough job of that. But if you're framing this in terms of bringing in palliative care teams for patients in the end-of-life phase of care, at best, some studies have shown that only about a fifth of cancer patients get that offered formally. And so what happens is, in the U.S. at least, you know, we've got 600,000 cancer patients each year who are dying of cancer, and a huge chunk are admitted to the hospital in the last month of life. I'd actually be very curious. I didn't prepare to look at what those stats are in Canada. And then if you look particularly at post-treatment cancer survivorship care, you know, this audience here, again, preaching to the choir in terms of knowing the unique challenges there. Care is fragmented and poorly coordinated. It's not just the cancer care team anymore, not that it should be just the cancer care team at diagnosis and during treatment, but the cancer care team certainly drops more to the background in this setting, and there's not clear communication with those who are managing the other facets of care. And all those who care for these post-treatment survivors have gaps in knowledge about post-treatment concerns and surveillance. Cancer survivors themselves are seen less often by their care teams, are at risk for many possible late effects of treatment, and have many unmet needs in myriad studies. So unmet psychological and social concerns, persistent symptoms, and problems with functional recovery. So all of this is what, I'm going to move to the next slide. I'm going to, actually, let me back up for a second. So all of this is what led to the development and incorporation of OnQ Health, and my deciding to take a role in leading this company. And we developed what we believe is the first technology and platform that aggregates and disseminates clinical knowledge, clinical intelligence to be used by a variety of cancer care stakeholders, specifically for the purpose of improving cancer supportive care delivery and survivorship care delivery, patient outcomes, quality of life, and reduced costs. There are a lot of certainly electronic patient-reported outcome systems available, and there are a lot of treatment pathways and care planning systems, but we we believe the first supportive care planning system that integrates electronic patient-reported outcomes with clinical evidence to drive integrated supportive care planning at the point of care. So just a little bit more about the impetus. I mean, some raw data here. This is some of my own work with my colleagues Linda Jacobs, Steve Palmer, Jude Mao, and others at Penn, where we did a cross-sectional analysis of 158 survivors, just basically a waiting room sample. So these were folks largely with breast and gynecologic cancers, but also some prostate, lung, and colorectal cancers. And these were 158 diverse survivors, on average 4.1 years from diagnosis. We found in this waiting room sample that almost all of them experienced at least one symptom they attributed to cancer, and on average, they reported 10 symptoms. You can see those over in this graph on the right. The blue is male and the pink is female, so a lot of issues that would surprise you around menopausal symptoms in the female population, certainly memory, concentration, depression, anxiety, worry, sleep, etc. What we knew symptom prevalence to be a problem. That's been documented in many prior studies. What we were really seeking to articulate here or evaluate here was how are we doing with managing, identifying and managing these symptoms. And so we asked patients their perspective on this, and half of them said that while they may have discussed these symptoms with providers, half of them said there was little to no improvement in outcomes after discussion. And this next statistic has been mirrored closely in other studies. Only 8% of these individuals were referred to supportive care services that might be able to help them in managing these concerns. So all on this call, I'm sure, are quite familiar with survivorship care plans. This is one of the studies I led in my role at Penn. I led a 13-site project describing the status of survivorship care plan delivery across Livestrong Center of Excellence affiliated academic and community cancer centers, and then exploring the feasibility and outcomes of implementing a standardized process. So in the first phase, we simply surveyed centers and asked them about what they were doing for their cancer survivors in terms of care plans. And remember that these were centers of excellence given dedicated funding by Livestrong to carry out cancer survivorship care. And yet even here, and we only looked at what was being done for breast cancer survivors, almost two-thirds of the centers served less than 10% of their population of breast cancer survivors. And it was an onerous process of preparation and delivery, a total of between 2.5 to 3 hours on average per patient to do this. So that's the other reason for developing a technology to help. What I was finding in my own clinical practice as I was doing this research and designing clinical program development is that it's not just about bringing the individual disease and treatment data, but harnessing that together and bringing that into one place to provide a treatment summary, but it's then what do you do with that information? So I would find when I sat with a patient in a room to deliver them a survivorship care plan visit, so I was screening for a variety of symptoms and concerns, and then really on the fly in the room, crafting an individualized care plan for them. And this is where the idea came to bear of why can't we harness technology to help us do this? There are evidence-based guidelines. There's a rich body of evidence in the literature on how to manage these things. If we could integrate screening for symptoms and concerns, integrate the clinical data that we know about the persons who are presenting to us for care, and marry that knowledge against existing evidence, we could hopefully not only improve the efficiency of care, but improve the quality of care and outcomes for this population. And ultimately, our vision as well at OnQ Health is certainly that we want to affect symptom management across the entire care trajectory, especially during the active treatment period, so that we hopefully can provide better symptom outcomes and avoid costly healthcare utilization events that also lead to poor quality of life in individuals with cancer. So here's that Deb Mayer data in greater detail on this slide. You see that pain was the top reason folks presented for ER visits and hospitalizations, followed by dyspnea, GI disruption, obstruction, fatigue, etc. So I'm going to tell you a little bit more about the platform. So the OnQ care planning system, or the workflow for how we integrate it, is that a patient completes a disease and treatment-specific questionnaire on a mobile device, so an iPad, some sort of a tablet, either prior to or at each clinical visit. The care team enters limited clinical data, and that the amount of data that needs to be entered is decreasing very quickly as we build interfaces with major electronic medical record vendors that are frequently used here in the United States, as well as integrations with registry databases. So we would pull in through interfaces that data on the patient's diagnosis and treatment characteristics. And then you see down here at the bottom a cloud. So our rules engine, our platform is incorporates a rules engine that sits in a web-based cloud and takes those data from the patient and the care team, and through CDS or clinical decision support, drafts a customized care plan for that patient that incorporates evidence-based guidelines, other forms of evidence, and helps incorporate quality standards as well. It generates this care plan, which then the oncologist or oncology care team, including nurse, can use to counsel the patient on the recommendations at the point of care. And then the patient walks away with a electronic copy as well as a paper copy. And if this is integrated the way we envision in the long haul, and it's actually happening in one of the piloted billings, if it's done at each visit, then when the patient returns, you actually have the patient reporting in on whether or not they engaged with the recommendations or interventions recommended to them and what impact they had, and therefore can have a continuous learning and adaptation of the plan. So one of the ways well, this chart rather illustrates multiple ways in which we're trying to address the existing care gaps. I've always been very impressed with how in Cancer Care Ontario at least, there is this systematic integration of ePro screening through the Edmonton Symptom Assessment Scale at the point of care. It's far from being the case in the United States. We have pockets of that going on, but typically when patients are seen in practice in our cancer care settings, screening for symptoms and concerns is very non-systematic. There's not, I mean, we have regulatory mechanisms in place that say we must screen for pain at every visit, but beyond that, which other symptoms are screened for is very non-systematic. So we address that in our system by embedding validated screening tools. In fact, the Edmonton is one of the tools we integrate, and is the one that was used at Moffitt Cancer Center's pilot project. Patient-reported outcomes, of course, then are collected in a structured way that can be used for data analysis later. And the real difference, I think, here between us and other efforts, whether they be commercial or academic, is that we don't just stop there by presenting symptoms to clinicians, what they are, how they're changing over time, but we tie this to personalized evidence-based recommendations that are rooted in evidence and current research and continuously updated by our team. And there's a lot of focus, certainly in the U.S., on adherence to quality standards. So one of the bigger programs in the U.S. is the ASCO-COPI initiative, the Quality Oncology Practice Initiative, in which cancer practices have to document their compliance with a variety of different quality metrics. For example, are they screening for pain? Are they implementing an evidence-based care plan, et cetera? And in the way that we collect our data and track the interventions provided at the point of care, we can help document whether or not that is happening. And frankly more important to me is we enable centers to be proactive rather than reactive. You're not looking, you can do continuous quality improvement by looking at what was done in the past and to try and improve that, but we're really trying to drive quality at the point of care by ensuring from the start that care is consistent with these quality metrics and evidence-based practices. And at least in the U.S., when a patient comes in typically to the office for any visit, whether it be at diagnosis, on treatment, or in the post-treatment setting, they're not typically walking out the door with a clear, well-articulated care plan for what's next and what their role is in that and what they're expected to do and what are resources that are helpful. And we'll often hand patients a one-page checkout sheet from our Epic EMR, for example, at Penn that says, okay, your next appointment is this, and these are the meds that were prescribed, and here's a list of your diagnoses. But that's as detailed as it gets, and so we're seeking to change that with our system. I'm going to skip through some of these next slides because it's really more U.S.-centric, some of the quality initiatives. Just so you know, we have developed initial care plan content for breast and gynecologic malignancies, for lung cancer, myeloma under development right now, as well as colorectal, prostate, lymphoma, and others. The way we develop our content is through working with physician, nurse, rehab medicine, psychologists, nutritionists, all kinds of faculty, cancer care professionals across the U.S. to help us develop the content that comes in our care plans. And so we have over 65 topics and expanding across the care trajectory. And our approach in providing patient-facing content, if you look on the right-hand side of this slide, we don't typically develop our own educational content for patients and families. What we do is embed links to faculty-vetted, well-established patient education tools and resources. And then on the left-hand side, you can see many of the guidelines that we incorporate into our care plan content. And Doris, in fact, has been very helpful to us in integrating the Canadian Association of Psychosocial Oncology guidelines. You'll see the CAPO symbol here for fatigue, anxiety, depression, and other sleep included among them. So I told you I would present to you data. That's what I'll do next. And then if we have some time, I'll give you a brief demo of the platform. Our first two foundational pilots really focused on evaluating feasibility, usability, satisfaction. We're at Billings Clinic in Montana and Moffett. This list actually isn't up to date anymore in terms of the others. In addition to those you see listed here, University of Pennsylvania is piloting our platform and a number of others. So I'll skip the demo for the moment and go into the presentation of the data so that I make sure I get to this part. And then whatever time we have before 12:45, I can give you a brief peek into the platform. So these are the data that we presented at the American Society of Clinical Oncology meeting in October of this year. Just for a little bit of history, we only released our first version of our platform 11 months ago, so February of 2014. And we kicked off our first pilot project at Billings Clinic in the gynecologic cancer population on active treatment in the end of February 2013. So they were our first pilot center and largely used the platform in a population of advanced ovarian cancer patients at multiple visits while receiving active chemotherapy treatment. 4 months later, Moffett came on board and piloted our platform starting end of June of 2014 in a largely post-treatment breast cancer population. But this is very purposefully titled supportive care plans which is what we call our care plans for managing active symptoms and concerns across the care continuum. Because at Moffitt, even though they largely were looking at a post-treatment breast cancer population, they didn't evaluate what you would consider a classic. They didn't implement or evaluate what you would consider a classic survivorship care plan with that treatment summary, the surveillance plan for follow-up, and the education about late effects, what to report, and how to prevent them. What they instead did was use that same core supportive care planning to screen for active symptoms and concerns and manage them in this largely post-treatment breast population. Does that make sense? I think the answer is yes. So between these two sites, we actually consolidated the data, even though they were in two different populations, GYN on treatment, breast post-treatment, because the aims here were really about feasibility, usability, and satisfaction. This is a very busy slide. You've heard a lot of what I said already, so I'm just going to hit the highlights. The goal here was to enroll 100 patients and their providers in this study, 50 GYN on treatment, 50 women largely post-treatment, and that each patient coming through on this study would fill out an ePro assessment at the point of care and then be given an electronically generated personalized supportive care plan by their care team during their office visit over a 3-month period. At Moffitt in the breast population, because it was a follow-up patient population, they got only one care plan. At Billings, since it was an on-active treatment GYN cancer population, largely ovarian, they typically got about 3 care plans per patient. And we specifically looked at feasibility, usability of the platform from both the patient and provider perspective. We did those evaluations, obviously, from a post-test only perspective, and we used both patient-facing and provider-facing surveys, as well as looked at statistics from using platform data. So, if, for example, what % of questions did patients answer in the questionnaire? So did they get through completing it, et cetera? And then our goal was to also look at adherence to the care plan and recommendations by doing a post-test survey, so that after the patient had the visit and got their care plan, we would query them later, about 6 weeks later, and say, hey, you were told in this care plan to go do exercise for fatigue. Did you do it? How helpful was it, and why or why not? That analysis I won't present today. Those data are still under analysis. So I'm really just going to present today the feasibility, usability, and satisfaction. And what you'll see here is at the time we presented these data at ASCO in October, ASCO Quality in October, we only had a total of, let's see if I can add 64 patients. 43 patients at Moffitt in the breast population and 19 at Billings Clinic in the GYN cancer population. There are a variety of factors that influenced why Billings didn't enroll as many in a longer period of time, including change in leadership and other institutional factors. But so what we're looking at here, though, in terms of the actual data presented at ASCO, is only 23 patients that we had comparative data on, because not all of the folks had gotten to a 6-week follow-up time point yet. So you'll recognize, obviously, that this is very preliminary data. And I didn't update it for today's talk because we haven't had time to do another formal analysis of these data yet. We're in the midst of preparing an abstract for presentation at another meeting, so I'll have updated data later. So a total of 23 patients with pre-test to post-test data, and for providers, a total of 10 providers. The NCCC just simply means the Nationally Designated Comprehensive Cancer Center, that's Moffitt, and the NCCCP, which is no longer the correct term to use, but it was an NCI-designated community cancer program, which was Billings. So our results in some showed high patient and provider satisfaction, feasibility and usability, including improvements in communication. I'm going to dig down into a little detail first about the qualitative data. In addition to doing post-test feasibility, usability data, we did also do interviews with both patients and providers. And I present to you here some select quotes from the patient interviews to date. So the themes that have come out from qualitative analysis and that initial cut of data analysis were improving communication with provider, providing helpful, accessible information, and utility for managing symptoms. So some of the quotes you see here are, the care plan and the assessment reminded me to bring up issues. It helped guide the discussion at the visit and gave my doctor a better overall picture of what's going on with me. I was able to touch on all key points, and my visit was much more thorough because of this care plan, and it provides helpful information that everything I need is right there. One patient even commented on how she helped another patient, a relative, out by sharing her personal care plans with that relative because her symptoms were the concern. Were the symptoms of concern of this relative. And there were a lot of comments about wishing they had had exposure to this care plan earlier in their care trajectory prior to being involved in this study. Even the gyne cancer population, we picked up many of those women maybe third, fourth cycle into a 6 to 8 course of carbotaxol, typically chemotherapy for gyne cancer. What we heard from providers, and at that time we had only interviewed 4, but now we've interviewed 8 providers to date at the 2 centers. These are direct quotes about improving efficiency by helping summarize not only the symptoms and concerns, but then providing tailored care plans that automatically brought in recommendations and resources for their patients. Helps focus the visit, allows me to direct the encounter to patients' needs and goals of care. And one of them even said, it's really so great, it's what you and I would want if we had cancer. So in terms of the quantitative data, patient satisfaction with the care plan was on average about a 3.8 across the board on a 1 to 5 scale in terms of usefulness, communication, management of cancer care and resources, and recommendation to others. Patients said it was very highly usable. The numbers in red at the bottom, you want them to be low. The max scale is 0 to 100 here, so the things that they stated were easy to use, confident using. And then on the bottom, there were some concerns about maybe it needing to be a bit more streamlined. So some of that we've been focused on. See, I think I have the provider. Oh, provider satisfaction again. The providers actually rated the care plans a little more highly even than the patients. So again, on a 1 to 5 scale, the average score in total was around a 4.5. And I'm breaking that out by item to show you some of the more granular points about satisfaction. Recommending others to use helps me address patients' concerns and treatments, would recommend as clinical decision support. And by the way, these measures were a composite of measures developed for other PPRO studies, such as Donna Berry's work, that we adapted for use in this study. And providers reported high usability as well. Some of the cumbersome, awkward to use when we drilled down into that more, a lot of that came from our interactions at Billings Clinic, where when patients came back in for the 2nd, 3rd, or greater visit, what we've not yet developed well enough in our platform is how these care plans adapt to change in symptoms over time. And so when we drilled down into this statistic in our qualitative interview data, that's really seem to be a large source of this, is that at the first visit it was extremely helpful, but we clearly needed to get more sophisticated about adapting the recommended interventions once patients moved beyond that first visit. So that's a key focus of development for us now, and we have a couple grants helping us to address that.